Hello, I'm Jonathan Kay from the University of Massachusetts Medical School, and I'm here at ACR Convergence 2020, sitting in my home office where I've listened to presentations so far all day as well as all day yesterday. And I'm going to talk today about a very interesting presentation and a very relevant presentation that Jeff Curtis gave at the Saturday plenary session, where he presented the results of the SEAM trial, a trial looking at maintenance of remission after withdrawal of etanercept or methotrexate in patients with rheumatoid arthritis and sustained remission on combination therapy. This trial is very relevant and important in clinical practice because we're faced with the quandary of what to do about a patient whose disease is well controlled on the combination of a TNF inhibitor with methotrexate. Do we withdraw the more expensive TNF inhibitor, or do we withdraw methotrexate, or do we continue them on the combination to prevent recurrent disease activity? There are two clinical trials that have been published which have addressed this question. The PRESERVE trial, which was published in 2013 in the Lancet, Joseph Smolin was the first author, which looked at maintenance, reduction, or withdrawal of methotrexate after treatment with methotrexate and etanercept in patients with moderate rheumatoid arthritis. This trial, the PRESERVE trial, took patients with moderate active rheumatoid arthritis who were treated with methotrexate between 15 and 25 milligrams weekly for at least 8 weeks, and they were randomized, or they were continued in an open label period to receive etanercept 50 milligrams subcutaneously in addition to weekly methotrexate. Those that had achieved sustained low disease activity with a DAS28 of 3.2 or less were then randomized into a subsequent double-blind period of 52 weeks in which they were randomized 1:1:1 to receive either etanercept 50 milligrams plus methotrexate weekly, etanercept 25 milligrams subcutaneously weekly plus methotrexate, or placebo plus methotrexate. The results of this study showed that patients who were assigned to receive either etanercept at 50 milligrams or 25 milligrams plus methotrexate did better in maintaining low disease activity than did those who were treated with methotrexate alone. The next paper that's relevant was the publication in the New England Journal of Medicine in 2014 of the PRIZE study. Paul Emery was the first author on this study, and this looked at patients with early active rheumatoid arthritis who were naive both to methotrexate and biologic therapy. These patients were treated for 1 year in an open label phase with etanercept 50 milligrams subcutaneously weekly and methotrexate weekly. And then those who had achieved low disease activity or remission were randomly assigned between weeks 39 and 52 to receive either continued etanercept at a dose of 25 milligrams instead of 50 milligrams weekly with methotrexate, methotrexate alone, or placebo for 39 weeks. So in this study, methotrexate and etanercept were withdrawn, or etanercept was withdrawn, or the dose of etanercept was reduced. And the endpoint was looking to see whether patients would remain in low disease activity or remission. And the study found that patients who continued to receive etanercept and methotrexate or etanercept at a reduced dose and methotrexate did better in terms of continued low disease activity compared to those who were withdrawn from therapy completely. The study that Jeff Curtis presented looked at patients who were in very good rheumatoid arthritis disease control. So this was a term that was used to define patients who were eligible for the study, and they had to be in this very good rheumatoid arthritis disease control for at least 6 months, according to the investigator. At the time of screening, they had to be in SDI remission of 3.3 or less, and they had to have been treated with etanercept for at least 6 months and stable doses of methotrexate 10 to 25 milligrams weekly for at least 6 months, with a stable dose for at least 8 weeks prior to the run-in. The primary endpoint of the study was SDI remission, SDI of 3.3 or less at week 48, comparing those patients who were treated with etanercept monotherapy to those on methotrexate monotherapy. The study design took patients who were on the combination of etanercept and methotrexate, and they were randomized 2 to 1 to either etanercept 50 milligrams subcutaneously weekly alone with methotrexate withdrawn, methotrexate 10 to 25 milligrams weekly with etanercept withdrawn, or etanercept 50 milligrams subcutaneously weekly, continuing with the methotrexate as combination therapy. Rescue therapy was allowed if patients met specific criteria, and the criteria were if they had moderate to severe disease activity at any time, low disease activity on at least 2 separate visits, or if at the 2 consecutive visits they had either low disease activity or moderate disease activity. So what did they find? The groups were relatively well balanced, and at week 48, in terms of SDI remission without disease worsening, 28.7% of those treated with methotrexate therapy, monotherapy, compared to 49.5% of those on etanercept monotherapy were in SDI remission. So almost twice as many patients remained in SDI remission without disease worsening at week 48 if they were continued on etanercept with methotrexate withdrawn, but fewer remained in SDI remission if etanercept was withdrawn and they were continued on methotrexate monotherapy. The proportion of patients who remained in SDI remission on the combination of etanercept and methotrexate was 52.9%, which was very close to the 49.5% of those on etanercept monotherapy. So this study showed that etanercept monotherapy with methotrexate withdrawal in patients in SDI remission was as effective as continuing patients on the combination. So in terms of time to disease worsening, patients tended to worsen sooner if they were on methotrexate monotherapy than if they were on either etanercept monotherapy or the combination. And recapture of disease control after rescue therapy was comparable in all groups. So the study showed that similar proportions of patients maintained remission with etanercept monotherapy as with continuing the combination of methotrexate and etanercept. The patients who flared, they were able to recapture low disease activity or remission with rescue therapy. And in terms of safety, the safety was comparable across the 3 groups. So this study suggests, in a trial design similar to the TEMPO trial, where you compare monotherapy with methotrexate, monotherapy with etanercept, or the combination of etanercept and methotrexate, in this case, withdrawing one of the 2 treatments in patients in remission, not low disease activity or remission, but SDI remission, that SDI remission is best maintained with withdrawal of methotrexate and continuation of etanercept, the TNF inhibitor, compared to withdrawal of the TNF inhibitor and continuation of methotrexate. So in clinical practice, this study suggests that the best approach, if you have a patient on the combination of etanercept and methotrexate, is to withdraw the methotrexate and continue the biologic agent to maintain excellent disease control. Now, the remaining question is, how can you predict who will best maintain remission or who might lose remission if you withdraw one or the other of the 2 drugs? So genetic or other biomarker predictors of remission maintenance will be appropriate to study in the future. This presentation was excellent. Jeff is to be commended not only on the study, but also on his typical excellent presentation style. I look forward to seeing more studies, not only Jeff's, but others at ACR Convergence. And I look forward to seeing you all again on Room Now. So for further information about this and other studies, go to the Room Now website, and I'll see you again soon. I'm Jonathan Kay.